So it is my absolute honour and pleasure to welcome you to the UK's first Patient Information Day on Fibromuscular Dysplasia. Thank you for giving up your Saturday and for travelling in this freezing cold to a cold, dark Manchester. Some of you have come from very far, from all across the UK, from Belgium, from Holland, and I'm very grateful that we can all be together today to share knowledge and draw inspiration and share our aspirations for FMD together. So why was today needed? Historically, and certainly when I was in medical school, FMD was always thought of as a rare and benign condition. But we now know that it's multifaceted and can affect people in multiple ways, and it's less rare than we think and can often be more serious too. So since forming our FMD specialist interest group, I've been contacted by patients and medics across the UK asking for specialist advice. There is no, as such, specialist FMD centre in the UK, although there are many people with a specialist interest who have got good intentions to try and improve this. Patients are seeking support and seeking answers, and the majority of advancements in FMD knowledge have occurred in the last 10 years with significant contributions to the literature by European groups and American groups. So it's important for us in the UK to also start gaining momentum and to join this quest for knowledge and present the latest understanding of FMD, which I will do today, including some of the hot off the press paper releases, the first consensus paper, some new genetic data. But lots of questions remain. So let's get started. What is fibromuscular dysplasia, or FMD as we'll call it from now onwards? So FMD is a condition that causes narrowing, or what we call stenosis in the medical world. Let me see if the mouse works. So narrowing and enlargement, so aneurysm, of the medium-sized arteries in the body. This can affect one or many arteries of the body, and it causes reduced blood flow from these narrowed arteries, which can affect the function of the organs. It is regarded as a rare disease, and as such is poorly understood. What's very important to highlight today is that people are affected to varying degrees, from completely asymptomatic that wouldn't have been known about had you not had a scan, for example, to be a kidney donor. Minor, but it can also be much more serious, as many of you will be able to encounter today. So it's very important to know that not all the information presented today may be relevant to you, or means you will encounter it, and it's very important to speak to your medical team for specific advice on how you may be affected. So who is more likely to have FMD? We know it's more common in young individuals and more common in women. So approximately 80 to 90% of patients with FMD are women. Although less common, men may also may develop FMD and may have a more aggressive course with a higher frequency of these aneurysms that I showed you about, and tears, also called dissections. In the CORAL study, which was a study that recruited in the States where they were scanning people for renal artery stenosis, interestingly they found that 4 to 6% of potential kidney donors, the CORAL study and potential kidney donors were found to have FMD. So without symptoms, they were just found to have FMD. So the prevalence in the population is expected to be 4 to 6%. Slightly less common, affecting the neck and the brain arteries, so cervicocephalic FMD. Of all patients who suffer with high blood pressure or hypertension, it's about 0.4% of the general population who have FMD. Much higher in children, so 10% of all cause of high blood pressure in children. And the average age of diagnosis is roughly about 47. What causes it? So the exact cause is not yet known. It's likely that there will be an interplay between a number of factors, environmental factors, genetic factors, but it's not yet known. What we do know is that it's not an inflammatory condition. So in other words, the blood vessels are not inflamed as you might get in vasculitis, for example. We know the narrowing is not caused by atherosclerosis, which is furring of the blood vessels that you might see in increasing age, smoking, diabetes, obesity, high cholesterol. It's not caused by that. And it's unknown, in view of the fact that there is a high recurrence in women, is there a hormonal influence? There's a lot of work going to look into this, for example, estrogen or progesterone. So what are the risk factors? So in some registries, roughly 1 to 7% of cases display an inherited pattern, and it can often coexist with other genetic conditions that affect the blood vessels. We know that mechanical stress from trauma, arterial wall stress, smoking, etc. may play a role. There's this query raised about whether female hormones may play a role as well. We do know that smoking, either being an ex-smoker or a current smoker, is associated with a more aggressive course of the disease. And there are no specific genetic tests to diagnose FMD at the moment, but there is some exciting work taking place around this gene called factor 1, in which there seems to be a slightly higher predisposition to develop FMD if you carry this. And having SCAD, so spontaneous coronary artery dissection, that's where you have a tear in the blood vessel of the arteries leading to the heart. There's a high incidence of having FMD if you have that. So what does it look like if you were to look at a histology sample? What we see is that instead of a sort of a round, smooth blood vessel, we see this abnormal proliferation of cells and a slightly distorted architecture of the arterial wall. But these days we don't obtain pathological samples, so we don't make the diagnosis based on histology. The diagnosis is made using radiological methods. So the radiological methods that are commonly suggested would be a CT, or a computerized tomography scan in the first instance, or MR scan, a magnetic resonance angiography scan. In certain expert centre where there is a lot of experience using duplex Doppler intravenous ultrasound scan, you may also find it that way, but that's not recommended routinely for the testing of or the diagnosis of this condition. So what do we look for? And I know our radiologist will show you some pictures, and so will some of our other speakers. But there is this typical string of beads appearance, it's described. And I've just included a picture at the bottom to show you. So the string of beads appearance on CT or MR angiogram, this is called multifocal FMD. In other words, it affects more than one spot in the artery. This is the majority of cases of FMD. But in the minority, you will get something called unifocal FMD, which is a much more sort of a larger, smaller, but only one area of the artery has this tight stenosis. In that form, it's more likely to present with downstream ischemic effects. In other words, the downstream organ will be affected. So here are lots of pictures. I appreciate it's not necessarily showing as well, but this is just to try and demonstrate how it can affect multiple arteries of the body. So this particular picture over here shows you the multifocal form in the internal carotid arteries. Those are the arteries leading to the neck. We've got here, for example, focal FMD in the kidney arteries. That's just one tight narrowing. So instead of this black dye flowing all the way through, you can see that there's a block happening over here. There are also lots of other findings that we are noting now with more and more radiological scans being performed. We're seeing, for example, aneurysms. We're also seeing tortuosity, or an S sign. So instead of being a sort of smooth pipe appearance, you've got this S-like curve in the vasculature. Which part of the body can it affect? FMD appears most commonly in the arteries leading to the kidneys, but it can affect the arteries to the brain, the heart, the abdomen, the arms and the legs. And new registry data is now showing that more than one blood vessel is affected in roughly about 2/3 of patients, so it may be in other arteries of the body as well. And you may ask, well, how can this affect me? So as I mentioned at the start, some people with FMD don't have and may never have any symptoms of FMD. But in others, they may experience a number of complications, high blood pressure being the most common one, or even more serious complications such as tears of the artery, as we spoke about arterial dissection. When you have an arterial dissection or SCAD, for example, this can limit blood flow to the organ supplied by that injured artery. And you may require procedures such as angioplasty, which I'll talk about shortly, or specific neurosurgical procedures if there was an aneurysm that needed to be clipped, for example. Again, a slightly busy slide, but that's because this may affect everybody in different ways. As I said, these slides will be made available after the talk, but depending which part of the body is affected, we'll show you which signs you may get. So, for example, if it affects the kidney arteries, you may get high blood pressure. You may get slow damage to the kidney, leading to what we call chronic kidney disease or chronic kidney impairment. If it affects the arteries to the stomach, you may get abdominal pain after eating, unintentional weight loss. If it affects the vessels to the arms and the legs, you may get discomfort when moving your legs, arms, hands or feet. You may get cold limbs, weakness, numbness, and skin change colours. If it were to affect the brain, you might get symptoms such as headache, dizziness, blurred or temporary loss of vision, a pulsating ringing in the ears, which we now know is actually quite a common finding in FMD. You may experience facial weakness or numbness. Heart signs may include chest pain, rarely a heart attack, shortness of breath, sweating, and nausea. As mentioned before, this is not to say you're going to experience all these symptoms. It just depends which arteries are affected, if they are even affected to a serious degree. Professor Adlam will tell you more eloquently than me all about spontaneous coronary artery dissection, but at the outset, for those who've not heard of this, this is an uncommon emergency condition that occurs when a tear forms in one of the blood vessels in the heart. More than 90% of cases occur in young women without the usual risk factors for a heart attack. And 50 to 75% of patients with SCAD may have associated FMD. But interestingly, the reverse is not true. Only a small minority of patients with FMD will have SCAD. And SCAD can be associated with connective tissue and inflammatory vascular disorders. How is it managed? So whilst there isn't a cure for FMD, it can be treated effectively. So in Europe and America, as I mentioned, Professor Pursue, while you were out, who are the leading group, there are leading groups conducting research into FMD, head to pelvic imaging is recommended. This is not routine practice in the UK, and I'm just looking at my colleagues here who we know it's been challenging to try and get that adopted, but something that we're more motivated to do now that the international consensus guidelines are published. You may require surveillance, that means interval scanning, depending on what areas of the body are affected. Medical management may hinge on blood pressure management, so management with blood pressure tablets, in particular what we may call the angiotensin converting enzyme inhibitors or angiotensin receptor blockades, so agents such as ramipril, lisinopril, candesart and irbesartan, just to name a few. And now there is increasing evidence to support the use of antiplatelets, so for example aspirin, if there's a renal dissection or thrombosis, or specifically if any of the blood vessels to the neck or the brain are affected. But again, the international consensus guidelines support this being used in everybody. Would you agree with that, Professor Pursue? That aspirin is recommended not just if you have a complication, as prevention in patients with FMD. And then angioplasty I'll talk about in the next slide. So what is angioplasty? So what is an angiogram, first of all? So an angiogram is a type of scan used to have a closer look at the blood supply. So in this case, I'm showing you the blood supply to the kidneys. How do you perform it? You perform it by puncturing the artery under local anesthetic and then injecting a dye, which is called contrast, to outline the blood vessels. And then if the renal arteries are narrowed and the blood flow is restricted, then you can stretch this narrowing with a balloon. That procedure is called angioplasty. In contrast to patients who have the other types of renal artery narrowing, such as the atherosclerotic version, it is not routine practice to put a stent, which is a tube, in. Because we know that some of these can reblock again, they may actually cause more damage to the vessel wall, they may encourage tears, etc. So the procedure simply involves stretching the narrowed segment. I thought this was a really useful Twitter slide that I've stolen from Heather Gornick in the States and was retweeted by Dr. Drew Klein. This is a guidance for doctors. So your patient has FMD, now what? So they recommend scanning for aneurysms from the brain to the pelvis, as mentioned, but I thought this helped to break the condition down quite clearly. So are symptoms present? So only a minority of patients are truly asymptomatic, but ask them about symptoms to see if they have got any possible FMD elsewhere. Then also determine which of the symptoms are genuinely due to FMD versus other health problems, because it's not to say all symptoms will be linked to FMD. And then medical therapy, we've spoken about aspirin if the risk-benefit analysis is in favour of it, blood pressure control, pulsatile tinnitus management, which is the ringing in the ears sound. And then patient education, so inform people about warning signs, what are the symptoms of dissection to look out for, to know when to contact a medical professional. So you may ask, what can I do if I've got FMD, or if I want to let people know about FMD? So first of all, don't be afraid to ask your questions in your consultation. And if your doctor or your healthcare professional is unsure, you can signpost them to the FMD Specialist Interest Group, and I've included a link at the bottom. Sign up to Renal Patient View. So Renal Patient View is a portal whereby you can log in and see your own blood results and track your blood results with time. You can also see your clinic letters in certain centres. There's important advice to consider stopping smoking, because we know that smoking is associated with a more aggressive course of the disease. and keep an eye on your blood pressure. So patient information pages, I've included the link to our UK Renal FMD site, but also get involved in the FMDSA UK charity groups, the support groups, the European and the FMDSA, which is the American group, or in radar research, which I'll tell you about shortly. I mentioned earlier about when it would be important to see a doctor. So here are some warning signs that would be useful to know when to see your doctor. So if you have FMD and have anything like a sudden change in your vision, an ability to speak, new weakness in your arms or legs, chest pain with shortness of breath, the pain spreading elsewhere, nausea, then do seek medical attention immediately. And if you have any of the other signs or symptoms that I listed earlier and are concerned about your risk for FMD, then do please discuss this with your doctor. Lots of questions remain. As I mentioned before, we're still not sure what is the cause. What is the advice then on the oral contraceptive pill hormone replacement therapy? How do we know who will be more severely affected, considering that many people are not affected at all? Will it progress? How is best to monitor? Is there a genetic link? You can see that there are lots of questions that remain for us to answer. So where are we hoping to find the answers to these very important questions? And because it's a rare disease, we have to pool resources together. And the data we're getting from registries have really helped to pave the way in understanding this condition better. And I'll tell you a bit more about those registries shortly. So we need to pool data with data collection, research, and then also expert consensus on how we manage this further. We need to collaborate because FMD might not just present to myself as a kidney doctor, it might present to the stroke physicians, a hypertension specialist. So we really do need an MDT approach. And I've included that picture at the bottom. This is a friend of mine who's an interventional radiologist in Vancouver. And he sent me this picture just to show how you can get FMD in multiple parts of the body in an attempt to try and raise awareness. So there's a lot of information on Twitter, for example. So Heather Gornick, who I've included here, has tweeted some of her suggestions on how best to manage FMD. Here she's spoken a bit more about the aspirin link. So we do really need a multidisciplinary team and multi-speciality approach to tackle this. So just a little bit more about the registry. So as mentioned before, the European and American registries are very much leading the road in this way. Professor Pursue will present the most up-to-date numbers, but from what I could see on the internet, we have roughly 687 patients in the registry. You'll tell us better. 78 with SCAD. It's been found to be familial in 2% of cases. The registry has shown that FMD is frequently overlooked, specifically when you don't have symptoms or you just present with more neurological signs. And the mean age of diagnosis actually exceeds the 47 I mentioned earlier. And 2/3 of patients can have FMD in multiple arterial beds. Data from the US Registry, so that has just short of 2,000 patients and more to the 1,900 range. FMD was incidentally found. In other words, you didn't go in looking for FMD in 5.6% of registrants. So the patients came in with headaches, pulsatile tinnitus, which is as I mentioned, the whooshing sound near your ears, or neck pain. But a larger number were found to have other vessels of the body affected, so 74% the vessels to the neck, 36% to those higher up in the brain. And a large number having an aneurysm or dissection at diagnosis. So they very much recommend that all patients with FMD should have brain-to-pelvic imaging. So it's very timely that we have this hot off-the-press international consensus guideline to share with everybody. And this is the go-to guide on the latest understanding in fibromuscular dysplasia. And this has been heavily influenced by Professor Pursue and David Adlam, who will be coming later. And that's the link that shows us what expert consensus there is on diagnosis, management, and advice to patients with FMD. So what are we doing about this in the UK? Because we very much need to catch up in the UK. So we formed a UK specialist interest group in 2016. This was under the banner of the Renal Rare Disease Registry, which is also called RADAR. So our members and our affiliates include adult nephrologists, pediatric nephrologists, an interventional radiologist, hypertensionologists, a pharmacologist, stroke specialists, neurologists, neuroradiologists, cardiologists, and patients. So what is RADAR? It's basically a database that patients can be enrolled on. And all that does is that it stores your data so that you can be approached for entry into future studies. So it helps us enroll people from all across the UK, because in our individual centres we won't have enough patients on our own necessarily to conduct meaningful research. So as I mentioned, patients consent to being approached for inclusion into other trials. Now our hope is to use RADAR as a platform and a starter for 10 to enroll people onto ultimately a registry database which will be completely aligned with the European registry. It's a very progressive registry and there's absolutely no need for us to be doing this separately. I had hoped to update you more in that regard today, but we're still waiting confirmation of the funding to enable us to take this registry and epidemiological study forward. But watch this space, hopefully in the next few months. And then most importantly, we're all on the same side, and the power of patients in progressing FMD I think will be enormous. In the US, for example, you have Pamela Mace, who is a phenomenal, inspirational lady who has very much helped to form the FMD group in America, which now funds the FMD research, the FMD registry in the States. The fantastic ladies in the UK, we've got Karen there, we've got Angie in the middle, and Sally B, who have also helped to try and mobilise interest in the UK by forming of the FMD Society here. And Kathleen is also here. There's Kathleen. Kathleen, who is also multilingual and is helping to raise awareness in Belgium and Holland. Am I right about that? As a group in Holland as well. So we can just see how our reach is so much stronger with patients included. There's also this group that I was only made aware of after the meeting in Brussels last year called Whooshers. And it's an online forum and information centre for people who suffer with pulsatile tinnitus, the whooshing sound near the ears. Social media will definitely help us in the UK to spread our word. So we very much are piggybacking on the great work that the Beat SCAD group have done, who have helped to raise a lot of awareness, and I know have contacted many of you today. Karen will tell you more about the Fibromuscular Dysplasia Society of the UK and Ireland and how she's managed to help us become a member of Genetic Alliance UK to again spread our reach and how the word gets spread. But in the UK, we still need to raise awareness and educate amongst medical professionals and healthcare professionals in general. I thought this was something to let you know about as well. In the States, they felt that the whole FMD movement was mobilized after an article that appeared in the Wall Street Journal in 2009, estimating that 5 million Americans may be affected. And that again helped to raise awareness amongst the public. Amongst the medical professional, there's a group called Medics for Rare Diseases. They started out as a group of medical students and they're now junior doctors, and they help to raise awareness about rare diseases in the UK, and they've put on blogs for us on FMD and help to tweet and raise information for today. And then again, I've taken something from Twitter that the Vascular Medicine Society had a 12 days of Christmas raising awareness of rare diseases, and they included a shout out to FMD at the end of last year. So future research, we now know that the face of FMD is evolving from a rare disease of kidney arteries just affecting a minority of cases to what might be a systemic disease affecting not just young women and can affect many artery sizes. So in conclusion to my talk, FMD is not as rare as previously thought, but it's only rare if you don't look for it or you don't know about it. There's many questions to be answered, and we need a collaborative approach to recruit enough people into studies to help answer these questions. People can be affected in many ways, from mild to severe, and not all information presented today may be relevant for you. And in the UK, we have our patient support group, we've got our research platform, which we're hoping to use to take this into a more formalised database and research. Thank you to all the UK specialist interest group, and I've included a call to everybody who's collaborated with me on this mission across the UK, including our FMD and SCAD patients, and including our colleague Professor Persu in Belgium. Thank you very much.